To introduce our speaker today, Dr. Robert Gatenby. He's the co-director of the Center of Excellence for Evolutionary Therapy and the chair of the Department of Diagnostic Imaging at the Moffitt Cancer Center. Bob is a real innovative thinker. I've followed his work for a long time, and he aims to put these evolutionary perspectives into action, into practice in the clinic. He's also an editorial board. He's also a member of the editorial board of Evolution Medicine and Public Health. And our discussant today is my colleague, Shelley Hwang. She's the Mary and Deryl Hart Distinguished Professor of Surgery and Chief of Breast Surgery at Duke. She's my colleague at TRISEM. She's served on the advisory board for more than 6 years, and she's always incredibly giving of her time, her expertise, and her perspective. So thank you very much for joining us to give some perspective, Shelley. Okay, I'm going to turn things over to you, Bob.
Thank you. Let me just share my screen, which always a little traumatic, and I'm hoping everyone can see it.
We can see it.
Great.
Okay, good. Okay, just as a brief introduction to the Moffitt program, we began about 12 years ago when we began to embed mathematicians into the Cancer Center, and the idea was to recapitulate the physical sciences paradigm of research in which there's theory and experimental work going together in lockstep. We view cancer as a complex dynamic system. We again use the physics paradigm to link mathematics and theory with experimentalists and clinicians. We quickly decided upon evolution as a unifying framework of first principles. And so we now have 9 faculty mathematicians and 2 evolutionary biologists in this program. What I'm going to focus on today is really just oncology. I mean, there's many opportunities and topics to look at, but I really want to talk about therapy. And I'm going to show you an example of what is now called personalized medicine therapy, and that's matching treatment to molecular properties. This is an example of a woman with metastatic lung cancer. She has an EGFR mutation, was treated with erlotinib, or there's a number of TKIs now that target that mutation, and had a really great response, really a triumph of personalized medicine. The problem is that they just kept giving her erlotinib, and very quickly resistance developed, and the tumor progressed, and had to be withdrawn. The general principles that we sort of go with now is that there's at least 1 billion cells in every cubic centimeter of tumor. When there's a huge heterogeneous population, it's almost inevitable that any application of a perturbation in the form of therapy will select for a resistant phenotype. But clinical resistance requires that population to proliferate. And that's governed by Darwinian forces. And that's the point at which we've now focused this, arguing that personalized medicine should not only be looking at targets, but also looking at the evolutionary dynamics of individual patients and individual cancers and individual therapies in trying to prevent this sort of occurrence. We sort of approach this as a game theoretic problem. Essentially, the oncologist is playing the game against the cancer. The oncologist plays the game by applying a therapy. Cancer plays the game by adapting. The oncologist has 2 huge advantages in this game. One is that it's a Stackelberg game. That is to say, it's a leader-follower game, meaning that the oncologist always plays first, the equivalent of the white pieces in chess. The cancer cannot begin to play in the sense that it cannot begin to adapt until the oncologist has actually applied therapy. The second thing is that the oncologist is sentient. He can play dynamically, can change therapy, and anticipate future changes, whereas an evolving population, like any evolving population, can never anticipate the future or adapt to something that's not seen before. And so the problem is that cancer therapy is typically given, and this is for decades, has been given according to the dogma that you apply a treatment at maximum tolerated dose continuously until progression. And so what we'd argue is that in doing so, the oncologist basically gives up both of these critical advantages. And in fact, because therapy is changed only when the tumor progresses, it in fact is reversed. The tumor is in fact leading the game while the oncologist is following. So if you translate this into just general therapy, suppose that you have a cancer population that is mostly sensitive to whatever you're giving it, but there are some small number of cells that are resistant or can become resistant very quickly. You give maximum tolerated dose, an overwhelming amount of treatment, just short of killing the person. And you have a fabulous outcome, tremendous reduction in the tumor size. The bad news is what you've done is select for a population of resistant that is resistant, and you essentially eliminated all of their competitors. You can continue to apply this therapy, and as successful as it was initially, it becomes progressively less so. So you get really a competitive release. An alternative therapy, and there are many ways that you can add evolutionary dynamics to therapy, but one of the ways that we've done this initially is what's called adaptive therapy, meaning that when we apply therapy, again, to this mixture of population, the treatment is actually simply not the maximum tolerated, but the minimum necessary. The idea is just to knock down the tumor population, but to explicitly leave behind a significant population of sensitive cells. Therapy is then withdrawn. While the tumor may begin to grow, you are no longer selecting for resistance. Typically, the sensitive cells have some fitness advantage because they do not have to use the molecular machinery necessary for resistance. And what we propose is then that this fitness advantage allows the sensitive cells to proliferate at the expense of the. And so while you go through this cycle and you return to the treatment being where it was in the first place, you also recapitulate more or less the subpopulations and continue to treat. And this has been tried out in preclinical models. And so what we're trying to do really is to use treatment as a forcing function that when applied at the correct time, induces oscillations near steady state. The first clinical application of this is monotherapy using abiraterone. Briefly, men with metastatic prostate cancer are initially treated with androgen deprivation, so-called castration or chemical castration. And invariably they respond over a period of time, and then tumor progresses. In about 2/3 of the men, it progresses because the tumor cells begin to make their own androgen. The abiraterone blocks the mechanism of androgen production. And so in these men with metastatic castrate-resistant prostate cancer, you typically get a response in about 2/3 of the men, and the time to progression is typically in the 8 to 16 months. To look at this, we modeled it, and I get grief about this model pretty much every time I show it. What we did was we were very simplistic. We just modeled the subpopulations based on their interactions with testosterone. We have T plus cells, which require exogenous testosterone. These are the ones that are sensitive to ADT, and these are the ones that are dominant in the initial cancer population. TP cells are the ones that make testosterone, and those are the ones that are sensitive to abiraterone. Notice that there is this cheating dynamic that can go on. The TP cells spill the testosterone into the environment, and so T plus cells, which require exogenous testosterone, typically delivered by the blood, in this case, can actually use the testosterone as a public good and act as tiers. And then we have the bad guys, T minus cells that proliferate independent of testosterone. There are a number of mechanisms that allow this, but we lump them all together. So we began modeling. We used standard Locker-Volterra equations. We then used a matrix game as a payoff matrix to look at how the oncologists interact with the tumor. And then Jinsung Zhang was the very brave oncologist who brought this into practice. And the way we did it was fairly simple. We would give an initial dose of abiraterone. The PSA serum markers would be monitored when the PSA fell to 50% of pretreatment values. And that response was confirmed by radiographic response. The abiraterone was withdrawn and allowed to regrow. When the tumor PSA went back to its original pretreatment value, treatment was started over again. And simulations predicted that we could control the tumor for a period of 2 to 20 cycles. This trial has now met its accrual goals, and we are sufficiently along that we have a median time to progression. We had a simultaneous group that would have been eligible for the trial, but were treated with standard of care. This is the outcome. 14.3 months was the median time to progression for the standard of care group, which is pretty consistent with what's published. The adaptive group had 30.4, so a 16-month increase in time to progression. The patients in the adaptive therapy arm received 41% of the dose they would have received under standard of care. A group of economists got involved in this, and they found that there was an average cost reduction of $50,000 per patient per year. No idea how they did that. But what we concluded from this is that clearly there is a competition coefficient greater than 1, so that the sensitive cells are reducing the growth of the cells, and that's kind of the area between the curves here. And then we basically, just to reiterate, is that the degree of suppression we assume must be a function of the total number of sensitive cells and this competition coefficient. Now, one of the let me just say the key demographic factors for the two groups was not significantly different. But one of the things that allows you that I think is different about clinical protocols that are designed through mathematical models is that it allows an analysis that goes beyond just the typical cohort analysis. In this case, we could use the mathematical model to examine both the cohort groups together, but each patient in the cohort. We collapsed the model into just the sensitive and resistant because the linkage between the TP and T plus cells was explicit, and we maintained ADP throughout this trial, as is conventional. We could then look at the upslopes and downslopes of the PSA in different clinical scenarios to estimate things like the growth rate of each population and the relative size of the pre-treatment resistant population. We'll first talk about the pre-treatment resistant population, and this was rather gratifying. When we took the mathematical estimates of the pre-treatment resistant population, we found that there was a very linear correlation between the time to progression and the size of the pre-treatment resistant population. We'll notice that at every fraction of pre-treatment resistant cells, the adaptive therapy patients did. We then wanted to know, this is just an example of this. This is a pre-treatment of resistant fraction of 0.3. This was standard of care. This was the adaptive therapy group. This man went 220 days before progression, and this man went 1,400 days before progression. We then wanted to know, what is the competition coefficient, critical value that we really didn't know prior to this, but just estimated. And we did this constrained nonlinear multivariable optimization to see what values of the competition coefficient gave us the what we observed. And what we found was that the global minimum was a competition coefficient of 7. We had estimated pre-treatment that it would be somewhere between 2 and 3. And this difference actually has surprising clinical significance. So this is we're just modeling a patient where all we're doing is changing the value of the competition coefficient. And this is a less than 1, so this is not much happens. This is the between 2 and 3, and what you can see is that in this case, every time the sensitive cells went up, and that's here and here, we flattened the curve so that the growth of the resistant cells essentially stopped. But this is a ladder-like thing. It just at each step, it kept getting bigger and bigger. Why that we felt that the best we were ever going to do was 20 cycles. But if we have 7, if the competition coefficient is 7, you'll see that as the sensitive population goes up, resistant cells go down. It's actually driving the resistant cells toward extinction, a dynamic that we did not anticipate. Now, 4 of the patients on the adaptive cohort remained stably on treatment for greater than 1,600 days. That's between 4 and 5 years, a number that would be unheard of for standard of care. And we look closely at each one of those, and I'm just drawing your attention here, is what we found was that if we hit a cycle that was just optimal, what the models predict is, in fact, in these 4 patients, the resistant population did not grow and in fact decline, and in fact may have declined somewhere near extinction. So why did the other 13 patients progress? And the answer is we screwed up. So this is the idealized PSA that we would have expected. We want to stop at 50% and then just keep going back. What actually happened is shown here. And you can see that because the radiographic confirmation of response often required 2 or 3 months, because we can get PSA values every month, but we were constrained by the insurance companies to have radiographic studies every 3 to 4 months, that we often had the PSA at a small fraction of its initial value for prolonged periods of time, sometimes up to months. And what the models are showing is that this by reducing this population too much, allow the resistant population to grow. And even if you can kind of constrain it, eventually you lost control. So oddly, the conclusion is that we lost control of the patients because we overtreated them. And so the conclusion is that to go forward, we need to undertreat. We need to treat less. We need to adhere to our guidelines. What the models showed was that had we rigidly changed therapy at that 50% PSA number, that we would have controlled indefinitely every patient in both cohorts. So we think we now have a very good handle on what we want to do next. I'll just show you that we now have a similar treatment going on with androgen deprivation therapy. Men hate androgen deprivation therapy. It has a number of toxicities, both physical and cognitive and logical. And so the opportunity to just be treated occasionally has been very popular. So far we have 8 patients on this trial who've been on it for more than 2 years, and none of them have progressive. So we have no data points on this, although I will point out that we're making the same mistake. We're over-treating these men. We're going to try to revisit this protocol to see if we can get this a little more accurate. So I'm just going to talk about this. So this is the end of this part of it. I would like to say that propose that formal integration of mathematical models into trial design really allows a new generation of clinical investigations that permits analysis of individual patients and also predictions about what you could have done better and how to go forward in the future. We've called this the after action analysis. It allows for a self-critique that allows us to rethink what we did in the protocol, what did we do right, and what did we do wrong. And I would propose that these sort of mathematically guided clinical investigations can reduce the need for huge and expensive studies that require typically thousands of subjects, which are the kind of the vogue in oncology right now. Okay, so I'm now going to just descend into pure speculation, and my apologies for this, and I can stop anytime. But let me just talk about for those of you who work in cancer, you will probably have had several experiences at parties or at family gatherings where you got backed into a corner by some angry relative and wanted to know why we haven't found a cure for cancer, and isn't it true that there is a cure for cancer, but it's been hidden from this vast conspiracy. But I want to focus on this, the term the cure for cancer. That's a concept that we take for granted. And I think it comes from the work of Ehrlich. This is over 100 years ago, this idea of magic bullets, the idea that you could find a drug that will kill cancer cells and completely have no effect on host cells. And this, it seemed obvious when the antibiotics came in the mid century. And so this is the cure for cancer, a magic bullet. And so I start with a hypothesis that the size, phenotypic diversity, and spatial dispersion of a typical metastatic cancer, it's simply beyond the ability for any single agent to kill it. So this idea of magic bullets, I think, is going to be very difficult to achieve. And so the question is, has it really outlived its usefulness? And the reason I started thinking this is actually because of a colleague, David Reed, who is a program leader for adolescent and adult oncology, and we had talked about using adaptive therapy to prolong control in teenagers who have metastatic sarcoma. And when we sort of presented this at programs for pediatric oncologists, we got beaten up quite a bit. That's nice, but it's really not acceptable. We want a cure. We are pediatric oncologists, and that's our goal. And so you've got to go back and sort of find another way. And so I started to think about certain things. One is that occasionally in both the adaptive therapy protocols, we would get to a point where a patient would get therapy, we would withdraw therapy, and nothing happened. Instead of bouncing back and going straight back up again, like most of them, you get into this regime where for years, sometime, nothing would happen, suggesting that this reduction of size can lead to a new steady state that can be fairly prolonged. The other thing, these are kids with metastatic pediatric sarcoma. It's an abysmal disease, but nevertheless, there are some patients that survive. There are some patients that are apparently cured by the chemotherapy. What does this tell us about? So this led to a hypothesis that cancer cure may depend not so much on the magic of the bullets, on the tactics that we use to apply it. And this comes from this idea that cancer is really, cancer cure is really an extinction process. And this is not new. A lot of people have proposed this. But in general, when non-evolutionary biologists think about extinction, they think about the dinosaurs. I mean, it's natural. And what we think about then is that this whole idea of the KT impact applying massive evolutionary force. And arguably, a lot of cancer therapy is very much like this. Giving so much chemotherapy that just short of killing the patient. The problem with massive evolutionary force is that it's indiscriminate. So 60% of the land animals, other than the dinosaurs, died during this mass extinction. And so, is this really the best way we can think about it? And this whole idea. So here's this is androgen deprivation therapy in a prostate cancer. PSA goes down and down and down and down and down. It's a very good therapy. I mean, it's really close to causing an extinction, and yet we don't. But could we do it better? And you probably already know all this, but I learned about background extinction and Anthropocene extinction, which is the sort of idea of transitioning extinction events from single cause, single event to this sort of multi-step, multi-cause that's observed during Anthropocene extinctions. And some people say, well, that maybe those, you got to remember the cancer's huge population, and yet there are plenty of examples in nature where our species has killed off populations that were easily in the billions, if not trillions. And there's even some examples of intentional extinctions, which I think is particularly interesting, and I just want to talk about for a second. So there, again, I'm probably telling everybody stuff they already know, but the Galapagos goat was a exotic species that it was introduced into the Galapagos Islands. It in the late 20th century proliferated very rapidly, began to crowd out the native species, and so it was decided that the people that were in charge of this began with basically New Zealand sharpshooters put into helicopters with automatic weapons, and they just flew over the herds and gunned them down. This is a first strike, but did it cause extinction? The answer is no. Some goats apparently became sensitive to the sound of helicopters or trucks and ran quickly into the forest, and so they were survivors. And this group began to proliferate. So they had to come up with a second strategy, and it was the Judas goat. They put a radio tracker on a female goat that was neutered. They sprayed her with hormones, sent her out. She became part of these small herds, and they used her to track them. The thing about this intentional anthropic extinction is that it's clearly multi-step, multi-cause. None of the perturbations that cause extinction in this case as a single agent could have eradicated the species. And so, is this applicable to cancers? And so, if we go back to this man with prostate cancer, notice that what we've done is we've reduced the population to something very small, very similar to that first strike of the Galapagos goat extinction. But what do we do? How do oncologists treat the patient? Well, they keep giving androgen deprivation therapy. They keep giving androgen deprivation therapy until they see progression. I would say that this is the equivalent of hunting the goats in helicopters when they've already learned how to run into the forest. Furthermore, there is the anthropic extinctions have particularly highlighted the vulnerability of small populations to extinction as a result of stochastic and allele effects, which can often become synergistic and self-reinforcing. And this idea of the extinction vortex has become popular. So the question is, can we use this extinction vortex in small populations, either after metastatic cancer is treated with an effective initial first strike, or in the setting of adjuvant, neoadjuvant therapies where we're trying to eradicate microscopic metastases. So we've modeled this, and so this is just giving one therapy. You get a response, you get this race to extinction. In this case, the NED means that it's not evident clinically, but if we but it does not get below its minimum viable population, so it sits here, and begins to increase. Finally, everything is resistant. The standard therapy is here, that you wait until it becomes evident, and then you give. Now the problem is that if you see the diversity of the tumor population and the size of the tumor population, significantly larger than it was at the minimum. And we would argue this is too late. This what we do is that to be able to measure a tumor, to see it and measure it, it's going to be a population 2 to 3 billion cells. It is at that point probably gotten big enough that no therapy will eliminate it. So the question is, the ideal second strike then is one in which a sequence of different demographic and ecological perturbations are applied at the minimum, at the nadir of the population. Why not just give those second strike agents with the first strike, which is actually how it's typically done in cancer therapy? You simply add, you give this drug, you've got this other drug, you add them together, and you give them together. And what the simulation showed is that when you do that, you're treating a very large population with 2 drugs. When you have such a large population, the odds are overwhelming that you will find a subpopulation that is resistant to both. Now, this may allow a longer time progression, which is actually the clinical observation, but it does not allow extinction. You need to apply the second therapy when you have the tumor at its population. That is the highest probability that you will cause extinction. So the principle is kick them when they're down. We basically the oncologists are very polite. They deal with it like a boxing match. They take their opponent to the mat, and then they go to their corner and wait for the opponent to get back up again. I would argue this is not a boxing match. This is a knife fight. And the second lesson from it is that the final nail in the coffin is virtually never the same as the first strike agent. In other words, you can do really well with cytotoxic drugs or antigen deprivation therapy, but you cannot kill the patient by just kill the tumor by continuing that. You need another strategy. You need some orthogonal mechanism of cell death and cell resistance. So here we go, androgen deprivation therapy. This is again a typical arc of a man with metastatic prostate cancer. Here the PSA is high. You begin androgen deprivation therapy, goes down, and starts to come back up again as it evolves resistance. Currently, second-line therapy, such as abiraterone, is when you get a recurrence, you try again. Our argument is that you should not with androgen deprivation therapy anymore, although you can continue it, but this is where you begin to add second, third, fourth strikes to cure. Now, to the oncologists, if there are any in the audience, this may sound familiar, and it is, and because it turns out to be virtually identical to the curative therapy that's been developed empirically for pediatric acute leukemia. This is decades of trial and error, but you can see what they do is they give an induction period. Typically, at the end of that induction, no tumor cells are evident in the bone marrow or in the blood. And what they've learned is, from history, is that when you do that, when you stop therapy, the kidneys stop. because the tumor comes back. And so what they do then is they actually give 3 more strikes: consolidation, interim, and so they different drugs, different sets of treatments, but they bang, bang, bang. And I would argue that, in fact, what they have done is empirically arrived at an extinction therapy. So, lacking magic bullets, and maybe we'll get them. I would argue that cure may be achievable through strategic combinations of regular bullets. None of these bullets by themselves are curative, but together, using a strategic combination of them and exploiting evolutionary principles, that we can actually work that are not currently curable. And so with that, I'll just mention the Evolution Cure Board, which is started at Moffitt about 6 months ago. And just to give you some idea, at the beginning, this is a group of, there's actually 3 evolutionary biologists in this group, a mathematician and 2 oncologists. Start with a meeting with them, this multidisciplinary group. There's develop a mathematical model, which you can see actually in the background. Currently, the patient, they're actually talking to the patient on Zoom. This group then does computer simulations, and when the board meets, and now these are mostly physicians in the board, but there's also the evolutionary biologists and mathematicians are here. They show computer simulations, and so they advise the oncologists on evolutionary dynamics that they think are likely to occur, and advise them on options for therapy. This is also a formal clinical trial, so that the mathematical models that are used to guide therapy, to advise the oncologist, are then validated against the actual clinical outcomes of the patient. So that we do one trial. And with that, I will thank many people I've had the privilege to work with, and as well as the funding, and be happy to answer questions. Share.
Thanks, Bob. That's fantastic. Really exciting work, and great to have Moffitt as part of the organizing committee for Club EvMed. So welcome aboard. Really great to have you.
Does Club Med mean that you go to the Mediterranean for conferences?
That's an idea. We'll have to raise a little bit more funding, I think. But if you have any ideas. I want to turn things over now to Shelley Hwang, my colleague from Duke, to give a bit of additional perspective, and then we're going to open it up for discussion. So go ahead, Shelley.
Yeah, thanks, Charlie. And Bob, that was amazing. I am always just so blown away by how creative that thinking is, because coming from a perspective in human oncology care, where we see patients all the time, and the strategy, which I think is rational, is to just keep treating patients as long as they're responding, just keep treating them because they're obviously responding. But the way you walk us through the evolutionary principles of what you're doing is just creating a super resistant clone is in fact what clinically happens. So what we see every day in the clinic is a manifestation of what your theory would predict. I just want to remind everybody that until antibiotics were actually introduced, humans used to die of infectious causes all the time. And I think this is very front and center right now as we're dealing with COVID-19. But for a while, we were really dealing with the same sort of very, persistent resistance in bacteria as well. But I think this is the same kind of evolutionary thinking that's allowed us to dial back a little bit on developing, fostering bacterial strains that are completely resistant to any therapy. And I think in one of your papers, Bob, you make a really nice point about how this was used in the farming industry, where pests were killed by kind of blasting all of them, and applying this sort of strategy has allowed for them to be completely extinguished rather than deriving a hugely resistant clone. So I think there are so many different applications to this. They're all fascinating. I think from my perspective, there seems to be incredible opportunity to carry this forward in the oncology field. And congratulations on finishing your first clinical trial. I think that's tremendously exciting. I just have a couple of questions. I think the first is you clearly used prostate cancer in your model. And I think one of the reasons you probably selected it is because you have a marker in PSA that you can detect. And I would assume that in that setting, the PSA level doesn't lag that far behind what's happening in the tumor itself. But for those tumors that don't have a serologic marker, and we're only looking at radiologic markers, and this is right up your alley, is that lag too much? I mean, is the horse already out of the barn? Has treatment already, or resistance already developed by the time you see radiographic changes? And if so, are there novel molecular markers that would help to determine where that correct titration point is so that you know only to drive it that far and no further? So that's my first question. And then I think my second one is, beautiful model in prostate cancer. And through this, have you learned any lessons about which cancers might be specifically or uniquely ideal to test in this way versus those cancers that are not likely to be successfully eradicated with this approach? So maybe you can answer those two questions. And just amazing talk, and congratulations on all your successes recently.
Let me just say first that I think that one of the things that we've been trying to do with this is to lockstep the theory, the mathematical model, and the clinic, so that as you see things that work out, then you have to say to the clinicians, can you measure this? Can we find ways to measure tumor burden more accurately than current markers, whether they're radiologic or serum? And so that dialogue is very important here. Right now, let me say that in preclinical models, we used imaging to change therapies. The problem is that we use the imaging frequently, and it really far more often than we can with in a clinical setting. I think we have to either change the way we image, so that, for example, maybe once a month we could image a couple of tumors. So not a full-out scan, but just a very limited scan that would be not very expensive, but would give you the clinical data that you need to fill into the model. We are obviously looking at circulating tumor cells and circulating DNA and other circulating macromolecules as a biomarker. And my guess is that clever people will be able to find other ways to do it. Ideally, what we'd want to know is not only what's the total tumor burden, but what's the population look like? How many? And again, all of those things I think are potentially addressable clinically, but we have to interest clinicians in doing that. If it's not right now, we sort of just take data because we can. And I think that we've tried to use this idea of weather prediction as an example. So it's not that you should get every piece of data that you can. You just get what you need to fill in the models so you can do the computer simulations. So that's a long answer to so there's a lot of work that's been done. The tumors that I'm very interested in are the ones that will respond but won't be cured. And some ovarian cancer is one that I think and has a good serum marker. I'm fascinated by things like small cell lung cancer, where you often get dramatic response to therapy. You reduce it to a very small population. It feels like we should be able to kill it. We do have multi-center trial going on in pediatric sarcoma. Again, a tumor where we have to do radiographic evaluation, but tends to actually get to almost an NED, meaning no evident disease, for most treatments, and yet almost always comes back. I guess those are the ones that I'm particularly interested in. I think that I guess really, I'm somewhat disappointed that I have not been able to get the oncologists interested in ovarian cancer, and I'm somewhat disappointed that we haven't been able to get involved in breast cancer. I also just point out that neoadjuvant and adjuvant therapy, the goal of that is explicitly to kill microscopic small populations, and we know from the results that it can be done. Adjuvant therapy does reduce the probability of metastatic disease to various extents kinds of cancer. So we know we can do it. Can we do it better if we exploit the small population dynamic?
Okay, we have a lot of really great questions in the chat. We've also had some people raise their hands. If you've posted a question in the chat and you'd like to ask it, please raise your hand and get in the queue. We're going to turn next to Joe, and then after Joe, we'll go to Molly and then to Brooks. Go ahead, Joe.
Thanks, Charlie and Bob. That was a great talk. It actually parallels a lot of my own thinking about this problem, but particularly I've been examining it from the perspective of antimicrobials in controlling viruses and bacteria, but it's really the same problem. So during the chat, I was making comments about the nature of the assaults. And so I really liked your idea about when the assaults should occur, but it's also, I think, a question of the nature of the assaults, such that when you're attacking various pathways in the cancer clones, the best way, from my view, would be pathways that are antagonistic to each other, such that variants that improve one response are detrimental to another. So in my laboratory, in bacterial experiments, we find that you end up with evolutionary traps where the bacteria can't evolve their way out, because if they get better at one thing, they're worse at the other. So trade-offs are your friends.
Absolutely. We've called them double binds. And I'm hoping that we can get people interested in doing that, because it's again, I don't think it's been a concept that it's been used in cancer therapy until now. And so there really hasn't been explicit investigation of this kind of approach. I completely agree. And we have some examples of that we can see. We saw, for example, a targeted therapy for P53 mutant didn't really affect the clinical outcomes in a patient. Really had very, very little effect. But when we gave those patients chemotherapy, they were extremely sensitive. They far, like an order of magnitude more response than you would have expected based on historical, for the same kind of cohort, suggesting that by adapting to the initial therapy, they made themselves vulnerable to the second therapy. And those, you can lay awake at night thinking about diabolical ways of cancer cells through these. It's great fun, actually. And it's I think we need, though, people that are really good in this, that know about this, to kind of start thinking.
Okay, let's move on to Molly. Molly, would you like to ask your question?
Sure. Thank you for such an interesting talk. And I was just wondering how some of these evolutionary dynamics might be utilized for cancer prevention. And I in one of your papers that you sent around, I was interested in this idea you were talking about, using the idea of how in ecology you have generalists and specialists sort of writ large, where the former are maybe more better adapted to these heterogeneous environments and the latter to more stable environments. And I guess what I am curious about, what I don't quite understand myself, is what aspect of the environment as the human body is stable versus heterogeneous that might facilitate dynamics? And I don't, know enough about cancer biology myself to know even like what aspect of physiology are we talking about here?
Sure.
How can you have a stable versus an unstable body environment? And then is there any way to use that kind of physiology and stability to implement cancer prevention therapy or strategies? And maybe it's something that you would do across the course of your life to maintain health, but it also, if it were something more aggressive, potentially would be, with aging where you have, these exponential rates of or risk of cancer, implementing something at that, at later life stages.
Sure. One of the things that interests me is the role of exercise in cancer prevention. I think that's been fairly well documented in several types of cancers. A consistent exercise regime reduces the risk for, I think, breast cancer is among them. And that it's commonly said, well, that has something to do with the immune system. I would have argued that what you're really doing is you are producing transient acidosis, and that you're changing the environment in some way that is detrimental to the cancer cells. And so I think that when we start to consider optimal strategies for prevention, that we should be adding ecology and evolution, where ecology is the ecology, of course, of the soft tissues into that consideration. Cancer biologists think about cancer growth as a series of mutations, but that's very, very simplistic. I mean, breast cancer don't start as a ball of cells; they actually start to grow in a duct, and there's a geometry to that, and they don't have blood vessels. They grow into the lumen of the duct in ways that make them vulnerable to acidosis, for example. And so you could put all that together. I mean, it's as a hypothesis. I think it'd be very hard to prove, but I do think that integrating these kinds of principles into things, rather than, cancer biology, so much of it is just you throw everything against the wall and see what happens. We just get data and data and data, and we're not really using any first principles or models to evaluate that and to then say, generate a hypothesis and see what happens. But it seems clear to me that cancer is developed through a series of evolutionary steps. That there's certain limitations involved, but there's also environmental selection forces, epigenetic changes, and so forth that I think that we need to understand and put into the prevention models rather than just globally, trying different vitamins and various things.
Okay, great question and interesting response. We're going to have time for 2 more questions. I'm going to call on Brooks and then on Bernie. Go ahead, Brooks.
Okay, so I absolutely love this. And I have a question that I want to kind of go back to, I kind of put in the chat a little bit earlier, and that relates to, as you were going through the adaptive model, what I was wondering is, you in a sense have started asking some of the questions I'm going to ask here, but in a different context. But what if, is the nature of the resistance itself important? It's kind of a way of reframing what Joe was saying, is that, the nature of the assault presumably depends on the nature of the resistance. And what if that resistance is not binary? What if it is, what if it is something that, is nonlinear over a long way, and it may have a threshold? And I think your discussions about acidosis, think about metabolism, think about oxygen, all of those things fit neatly into that piece, because, it affects the way your model is evolved, because you could just as easily say that the number of cells and tumor size is a proxy for changes in environment as it is for sizes of population.
Sure. Oh, absolutely. Anti-angiogenesis strategies, kind of was, if you're as old as me, you remember that, that was the cure for cancer that was, 20 years ago, 30 years ago. and it didn't really work very well, which I don't think anybody now would have said, well, you know, the cells can adapt so quickly. There's certainly ways around it, and yet integrated into a broader strategy, you know, the use of ecological perturbations, I mean, what that would be, as well as demographic perturbation in ways that make sense. And the neat thing about a demographic perturbation is that you may globally affect a population in a region rather than selectively. You're less selective than say for a demographic perturbation. So yes, exactly. I think that when we consider how we're going to attack the tumor, particularly when we get into a small population, we know, for example, that the cells are fragmented. They instead of a coherent population, if you look at after a neoadjuvant therapy, you know, a primary tumor is reduced to small fragments of tumor. You know, 20 cells, 30 cells, 40 cells. Those guys are really isolated. You know, and we can then begin to think in terms of both demographic, ecological. I mean, there's a lot of things that we can do. And as I said, you could step thinking about diabolical ways that you could cause them to die. But I think we need a broader idea, broader thinking about what evolution is in cancer biology, you know, and then applying that in ways that make sense. And you know, using data that we then start to develop in this model.
And your first strike, second strike could actually be an example of those kinds of ecological perturbations.
Absolutely.
Depending on what what the nature of the resistance is, you may be priming sensitivity for the second strike, and that may be why there's a difference between the coordinated versus the successive.
Sure, and you see how you then, we don't spend a lot of time thinking about what the mechanism of resistance is. It's interesting that if you were a pesticide manufacturer, you were required by law to have a resistance management plan to get it approved. You know, you need to understand what's the mechanism of resistance, how you're going to manage it. We don't require that from the manufacturers of cancer drugs, and I think those kinds of things really should be changed. But of course, we haven't thought about resistance so much. So it requires kind of a new mindset.
Okay, we're going to move on to the last question. It's sort of painful because there's so many great discussion points in the chat box, and I know
I'm looking at it. Thanks for all these responses.
Just so you know, that chat box will be saved, and so you can look at it later. But Bernie, why don't you go ahead and ask your question, and then we'll wrap up.
Thanks. This is some of the most exciting work that I've ever seen in all of evolutionary medicine. I've kind of got a question about the psychology of cancer treatment, and it bears, I think, on the degree to which these new approaches are going to be accepted and deployed. And the question has to do with the apparent trade-offs here between sort of long-term morbidity of some form, or at least long-term anxiety, and mortality. So I'm just wondering, from your experience, how has it played out if you give people with cancers, older people, a choice between a treatment that is likely to prolong their life by a couple of years, say, alternatively, this other therapy, there's a chance 5%, 10% of a cure. And you know, there's certain ethical, philosophical aspects of this as well, but also I think economic, and it's important for the degree to which these amazing new therapies are going to move into the mainstream.
It's funny, when I applied for a prostate cancer grant for the abiraterone trial, and got the worst reviews I've ever gotten on a grant, which is a very high bar for me. Really bad. And I even got trashed by the patient advocate, who said, well, no patient or doctor would ever consider a treatment that you're not trying to cure. Now, even though we know that abiraterone cannot cure a patient, the mindset is just so ingrained that that it's really hard to get people to think otherwise. That hope is kind of implicit in the way we give these drugs, and I think we have to be more honest about it, to be honest. But we did have patients decline, so they would get the 50% decline, and then they would decline to go into the adaptive therapy arm. They insisted on, they want to just drive it down as low as possible. It's just psychologically very difficult not to do that. Unfortunately, those patients progressed rather rapidly afterward. And again, it's one of those things that's intuitively appealing, but just dead wrong in terms of evolution. We also had one patient drop out of the trial because he just couldn't stand the pressure of changing therapy. You know, that him was just too anxiety provoking. So you're right. I mean, I think first of all, we have to be honest. We have to say, we can't cure you with this. There's no chance of you being cured of this. Or you know, here's the numbers. And then you can make a decision. And you know, now we can even see with abiraterone trial. I mean, I could imagine using it with curative intent if we can get these cycles correct, and if we do in fact get the resistant population driven toward extinction. You can imagine in some ways, I mean, that gives us another option. All of these things, particularly now, because we don't have good data, you know, requires a very frank and honest discussion with patients. And I just feel like we have to do that. And, you know, particularly, I mean, these discussions, I can't tell you how anxiety provoking all this was, because especially at the beginning with the abiraterone trial, we had no idea whether this worked. It was purely a theoretical thing that we did in animals, but did not know we could do it in people. So yeah, I'm sorry, that's a long answer. Basically saying I don't know what to do. But I think we have to, as we gain more information, I think it'll be a more accurate, informative.
In principle, even the cycling approaches could be presented in the context of a potential avenue to cure in some patients. Would that be
possibly correct? Yeah, yes. And that's been brought up as I've sort of presented the results. I mean, everybody notices that we are maybe driving the population that we can't control. We may in fact be controlling it in a sense that we're moving in that direction. And my answer is always, well, that's why God made oncologists. My anxiety levels are too high for that.
Thank you.
Okay, well, thank you all for joining us. Thank you, Bob, for a great talk.
Thanks for having me.
Not Shelley, but thank you, Shelley, for the perspective you provided. Thank you, Meredith, for organizing. This was a really great start to our program in 2021. And before we go, I just want to share with you the upcoming Club EvMed conversations. This was our first one. We have, I won't go through all these actually, because it would take a long time. We have Adrian Yagi next week with Aaron Blackwell. And then after that, we have Melissa Emery Thompson talking about aging. We have Christine Stabile-Ben with a very interesting and provocative talk. And you can scroll down and see all the other speakers that we have lined up. A really great program for you. So please join us again. We're going to be having these about 2 or 3 a month for the spring semester. So we hope to see you. Keep in mind that the day and time do differ, you know, depending on the availability of the speaker and our scheduling. So anyhow, thanks again, everyone, for showing up. Thank you, Bob. And
thanks for having me.
Next one.
Take care. Bye.